Moving on to the next complication that we're going to discuss regarding the pregnant mother, the postpartum mother, would be bleeding during pregnancy. So this section encompasses everything from early bleeding until late bleeding and postpartum hemorrhage. So when we're talking about early pregnancy bleeding, we're looking at something that happens before the halfway point of pregnancy. So something that's going to occur before 20 weeks of gestation. Now, prior to 20 weeks of gestation, the most common reason for vaginal bleeding, for bleeding during pregnancy, is going to be a spontaneous abortion. Spontaneous abortion is the medical terminology for a miscarriage. We also have concern for something called ectopic pregnancy, gestational trophoblastic disease, and then when we're at that mid-trimester, so something closer to that 20-week time period, we might be looking at something called cervical insufficiency. So we're going to break these down a little bit more here in a little bit. When we're talking about late pregnancy, we're going to be talking about after the 20th week of gestation. Some of the more common causes are that placenta previa that we have talked a little bit about, and then a placental abruption or abruption placentae. So first, let's talk about miscarriage. So again, as I talked about, or I mentioned previously, usually these spontaneous abortions are considered a pregnancy loss prior to 20 weeks of gestation. During that first 12 weeks, what we're looking at as far as a cause, we're going to talk about like genetic abnormalities. Genetic abnormalities or a hormonal imbalance of the mother. We could be looking at either a defect in the follicular phase or the luteal phase if it's related to mother's hormones. If it's related to a genetic abnormality, this might necessitate a thorough workup as to what occurred so that we can be aware of it for any future pregnancies. When we're talking about second trimester, again, that is usually due to some sort of abnormality with the mother's overall condition, not related to hormones. So if we've got like a poorly controlled diabetic, with that you have a very potentially, with a poorly controlled diabetic, a placenta that's just not functioning the way that it should. Obesity, thyroid disease, lupus, or other more maternal genetic factors. Maybe mom is carrying the genetic disorder. Poor choices, if we do heavy alcohol consumption, excessive caffeine intake, environmental toxins, these can also be factors during the second trimester related to the maternal condition and causes for a miscarriage. We can also define a miscarriage as a pregnancy loss in which we have a fetal weight of less than 500 grams. When we're talking about miscarriage, we need to be aware that about 10 to 15% of all pregnancies result in a spontaneous abortion. So when we talk about those 1 in 5, those 1 in 4 women who have experienced this, and then the majority of those losses are going to occur during the first 12 weeks of gestation. Occasionally it happens right around that 5th or 6th week of gestation, perhaps even before the woman fully realizes that she is pregnant. Then we talk about the different types of abortion as well, or spontaneous abortion. We have threatened, inevitable, incomplete, complete, or missed. So in a missed spontaneous abortion, that's exactly what I was speaking with as far as somebody not even realizing that they were pregnant. We do need to talk about what types of classifications of abortions that you will see listed out on the patient's medical record. When we're talking about that gravital term, para, etc., abortion living, that GTPIL, you can break out that abortion segment even further, and you might see an induced abortion, especially if this was like an elective abortion. You can have a therapeutic abortion in which the mother's life is in danger. You can also have an abortion in which the parents have chosen because it's therapeutic for the fetus and that the fetus would not have a good quality of life. Parents may choose to do that. And then, of course, the spontaneous as well. So, symptoms of miscarriage. How does a woman identify that she was potentially pregnant or was pregnant and has suffered that loss? So, the symptoms with a miscarriage are really dependent upon how far along that woman is in her gestation. Those symptoms are going to be a lot different at about 4 weeks of gestation, when you still basically have like that fetal egg sac. There's not a lot to pass as far as tissue, versus that 18, 19, 20 week of gestation where you have more of a placenta, you have more tissue, and that fetus is more fully formed and developed. Any symptoms that these women experience who are pregnant, if they have any of these vaginal bleeding, low back pain, cramping, or passage of products of conception, if they have any of that, we have to consider that this is a threatened pregnancy, that this is a threatened abortion until it's proven otherwise. When we're talking about bleeding in that first 6 weeks, again, as I just mentioned, you're going to have not a lot of passage of tons of material. They could have some heavier than anticipated menstrual bleeding, something that's has a more abdominal cramping. Some women might be able to pinpoint and say that was a really weird and heavy period. Okay, well, it wasn't. You actually miscarried a baby. At 6 to 12 weeks, we have some more moderate discomfort and increased blood flow. And then after 12 weeks, you guys, you have to really consider that these women are basically going through some labor, because we have to have that cervix dilate to some extent in order to pass along that fetus along with any retained products of conception. So when we're talking about management of this disorder, we have to look at diagnostic criteria. How do we identify this? We are looking at HCG levels, so human chorionic gonadotropin. So HCG is what's picked up, obviously, as you will have read about this in your textbook readings. HCG is the hormone that is identified by those pregnancy tests, the urine test, the venous blood draw test. They're all looking at HCG levels. HCG is released by the placenta. Okay, so during pregnancy, as that placenta grows and develops, more of that hormone is then excreted. Okay, so you should have HCG levels that trend up, like so, right? Well, if all of the sudden we're doing, this lady comes into the OB, the family clinic, or the emergency room with vaginal bleeding, and we check her HCG levels, and they're way below what we would expect for a person who's supposedly this far along in the gestation. We correlate that with the vaginal bleeding, and we say, hey, this is what's happening. That placenta has essentially detached, and you're having a miscarriage. Hemoglobin, obviously, we need to keep a very close eye on how much she is bleeding, and then white blood cell count, because this does place a woman at potential risk for infection. We could also perhaps have an underlying infection that could have caused this. We don't usually see that during the first half of pregnancy. It's not usually, that fetus is usually safe from infection, but still we're going to be concerned about that. Once that cervix really begins to dilate, miscarriage is inevitable. Again, prior to that 20 weeks of gestation, there's nothing that medical science is going to be able to do to save that fetus. We're looking at age of viability right around 24 weeks of gestation, 23 weeks. There are very, very few 22-week gestational babies that will make it to be alive 6 months later. The products are generally passed without intervention. So many times these women are able to miscarry at home, perhaps in the hospital if they're farther along with that gestation. But usually we don't have to go in and manually remove those products of conception. However, with that being said, occasionally these women will come in with heavy bleeding that's been going on for a prolonged period of time. We check a hemoglobin and we see that they're anemic. Their hemoglobin is 7, 6. They've had ongoing abdominal cramping. We might have some elevated white blood cell count, and then those three things together are going to give us a concern that we have retained products of conception. So as long as, like I said, generally this occurs, without any kind of medical intervention, but occasionally we have these retained products of conception. So you might have a tiny piece of the placenta that is still adhered to the uterine wall, and so the uterus is trying to expel that product, and in doing so we have this heavy bleeding, we have this cramping as it continues to contract, and then perhaps as well now we have an infection. That would not be an infection along with the retained products of conception is a cause for hospitalization. It's going to keep you in the hospital for several days. So we need to obviously get these retained products of conception removed. So there are two different ways. They can go in and they can do a suction D&C, which is the dilatation and curettage, or they can actually go in and scrape it with that D&C. Suction D&C is the one that you're going to see most frequently now. A few old school providers might actually do the tool suction D&C. But with the dilatation and curettage, the provider actually has to manually dilate the cervix in order to get the instruments up into the uterus to remove those little parts that are still adhering to the uterine wall. Once we have those parts, whatever that retained product of conception may be, that's going to be sent on to pathology. So if we are having a miscarriage, but we don't have, if we've had a loss of a fetal heart rate, but we don't have any vaginal bleeding as of yet, we do need to get that fetus out. We need to get that placenta out, otherwise it's going to put that mother at high risk, obviously, for infection. So we can do some medical management. We can again do that misoprostol or Cytotec, just like we would have used to induce or labor. So we're going to put that Cytotec in to stimulate uterine contractions to evacuate that uterus of all of those products of conception. It can cause some nausea, vomiting. And then again, mifepristone can again stimulate those prostaglandins to stimulate those uterine contractions, and then Cervidil or Prepidil as well. You do have to consider emotional support during this time. I have witnessed, even within the last couple of weeks, women who had an unexpected pregnancy, but in which this baby was very much wanted. This baby was very much already a part of the family. So we have to recognize some women come in and it doesn't seem like is emotionally trying to them. They're very, flat. They're there to do their business, to get in and get out of the hospital, get in and get out of the clinic. Other people are very different, and so you have to do that grief and emotional support, offering your chaplain, giving hugs. Up on the labor and delivery unit, they have little mementos that we can give, tiny blankets, little angel hats, something like that. Especially if subsequent miscarriages have occurred, you have to recognize how trying that is to a woman, and not only to the woman herself, but I've also seen partners struggle very, very much so with this. Bonding has already begun, hopes, dreams, all of that stuff. So we have to consider that emotional aspect as well. If those moms are Rh negative as well, we do also have to administer RhoGAM. And then self-management, reference your textbook on page 601 for talking about care after miscarriage. Following right on the heels of that, and you'll use a lot of that same emotional and grief support, is an ectopic pregnancy. So again, in this case, the woman is fully pregnant. It is important to understand that ectopic pregnancies that go undiagnosed or untreated, they still account for 3% of all pregnancy-related maternal deaths. Again, if we don't have a lot of prenatal care or access to care, I can see why this would happen. Other than that, there's no excuse for us missing an ectopic pregnancy. Women who have an ectopic pregnancy are less likely to have a successful vaginal delivery, a lot of times because of the scar tissue that develops. But let's talk about this a little bit. So an ectopic pregnancy is when a fertilized ovum implants outside of the uterus. So typically something is happening between the ovary and the fallopian tube, in which this little fertilized ovum migrates its way somewhere within the abdominal cavity and implants itself. Well, if it implants itself on the intestine, it's going to get a little bit of nutrition, it's going to be able to suck a little bit of life out of that intestine, but that intestine is not going to be able to tolerate a pregnancy. Most commonly, these implant within the fallopian tube. That is the most common location for an ectopic pregnancy. Also too, in an abdominal, if it might have already had like a tubal rupture, if this already here, and it like re-implanted someplace else. So the problem here with these is if we've had like tubal trauma, if you've already got scar tissue in your fallopian tube, if you've had a past history of an ectopic pregnancy and we were able to save the tube, if you've had some sort of abdominal surgery, if you have a history of infection that was pretty severe, like a severe GNC, chlamydia or gonorrhea infection in which the fallopian tube was infected as well, that could create some scar tissue, and basically what we call congestion within the fallopian tube, and that can impair the fertilized ovum from reaching the uterus. Smoking also puts you at risk, and certain contraceptive methods. So again, as I mentioned, the other thing would be like pelvic inflammatory disease as well. So what happens here is this nice little ovum has attached itself to something that's not going to be able to withstand it, or be able to handle its long-term pregnancy, and when that occurs, at some point we're going to have some vaginal bleeding. So our symptoms usually start around that 7th to 8th week of pregnancy. So usually at this point the woman has identified that she is pregnant. We've had a missed menstrual cycle. We've had a positive pregnancy test. All of a sudden we're complaining of a lot of tenderness, usually localized to one side, but you might see referred pain as well. It kind of is diffuse along the entire abdomen. The vaginal bleeding is very spotty because, especially if it's implanted within the abdomen, you're not going to see the bleeding necessarily coming through the vagina. Like if it's bleeding within to the abdomen, it doesn't have an outlet. So you're not going to see that per se. The symptoms with rupture. So if the ovum has implanted into the fallopian tube, you might see that spotty vaginal bleeding. But as that ovum continues to grow in size, that fallopian tube, in addition to not being able to nurture a pregnancy, is also not large enough to grow, and is not designed to grow with the pregnancy, so that tube will rupture. Now, when that tube ruptures, these women have sharp, severe, sudden abdominal pain and distension. Essentially, you have to recognize that they are hemorrhaging internally. You can have shoulder pain. This is referred pain due to the diaphragmatic irritation from the peritoneal hemorrhage. You have a positive Cullen sign, which is that bruising around the umbilicus, which is indicative of an abdominal hemorrhage. And then hypotension, again, and hypovolemic shock, again, because we had the blood pooling into the abdominal cavity instead of coming through the vagina. So anytime that a woman presents to the emergency room with any complaints of abdominal pain, you need to have a pregnancy test completed, and the providers are usually, and the nurses are usually very, very good about obtaining that right away to rule out any kind of pregnancy. It's important to recognize that an internal abdominal hemorrhage related to an ectopic pregnancy may or may not be related to vaginal bleeding. We may or may not have that present. There are other potential causes on the differential diagnosis that we have to exclude, obviously, like appendicitis, cholelithiasis, etc., etc. However, if the pregnancy test is positive, ectopic is suddenly going to hit the top of that list. In order to determine whether we have an ectopic pregnancy, we're going to do a transvaginal ultrasound. Usually at this point, it's usually early on, around that 7th to 8th week of gestation, and we don't do the abdominal ultrasounds until about 12 weeks of gestation. So the radiologist is going to read that report, and what they're looking for are those essentially retained products of conception. We're also going to draw those HCG levels, that beta HCG. Again, we're going to find a beta HCG level that's lower than normal. Might still be elevated, okay, because it takes a while to leave the body system, but we're going to see that trending, okay? Management. So, medical management, what are we going to do if we identify? Okay. We don't necessarily have to go right to surgery. We might be able to medically manage them. If the woman is hemodynamically stable, the mass measures under 3.4 centimeters, and the fallopian tube is intact, then we will administer methotrexate. Methotrexate is a chemotherapy type drug, or a chemotherapy drug. It is a chemotherapy drug. What do chemotherapy drugs do? They attack rapidly dividing cells. What is a fertilized ovum? It is a rapidly dividing, and there's a ton of rapidly dividing cells, okay? It's a folic acid antagonist in the way that it also works as well. So it's going to attack that folic acid, all of that folic acid that we've been taking for our pregnancy in order to have a healthy baby and no spina bifida. We're going to, as a nurse, when a patient comes in that is going to need a methotrexate injection, you're going to get a current weight. That is going to help us calculate, or a pharmacy to calculate, a therapeutic dose. Unfortunately, I have seen women that have required up to 3 methotrexate injections. Sometimes that's related to weight, sometimes like an incorrect weight that's gathered, and so we didn't get like a therapeutic dose. Other times it's like a really stubborn ectopic pregnancy. Methotrexate can be administered IV or IM. When these women come to, currently they come to the pediatric unit, where we have privileges to do what we call outpatient infusions, which when you get to your peds rotation, we'll learn all about. But those women come to the pediatric unit, and we administer that injection IM, and then we wait a little bit, and then they're able to be discharged home. When the nurse is administering methotrexate, because it is a chemotherapy drug, we have to take chemotherapy precautions. When we're talking about, and we've given this woman methotrexate, we have to tell them that they need to avoid pregnancy until they've been cleared by their medical provider. And again, they need to double flush the toilet after urination as their body excretes. Ongoing monitoring would include ongoing monitoring of the HCG levels and making sure that they're trending down. As I've mentioned, I have seen women have to have multiple methotrexate injections, and so if those HCG levels are still climbing and trending up despite our methotrexate injections, then we need to re-administer. If that tube has ruptured, or if the mass is larger than 3.5 or 3.5 centimeters or larger, they're going to have to go in and do a salpingectomy, which is the removal of the fallopian tube. Again, if the tube has ruptured, the main goal at this point is not to save these, organs and whatnot to be able to have future pregnancies, but essentially at this point the goal is to control the hemorrhage. So pre and post-operative care includes frequent vital signs, pain management, monitoring that H&H, and being aware of that RH status in RhoGAM. Trophoblactic disease is, or hydatidform mole, is very, very rare. So this is occasionally happens in about 1 to 1,000 pregnancies. It's a chromosomal abnormal fertilization. Trophoblactic cells are the initial cells that will eventually become the placenta, and these are what is also spilling out that HCG level, those HCG hormone, So what's happening here is these trophoblactic cells develop into the chorionic villi of the developing placenta, and these abnormally proliferate into this large edematous, cystic, avascular, transparent grape-like cluster. It's just a really weird thing. These fluid-filled clusters then, or vesicles, they grow very rapidly and they expand the uterus. It results in a larger than expected uterus when we're comparing that to gestational age. So we would anticipate your abdomen to be about this many centimeters at X amount of weeks of gestation, and suddenly you're at, a number 3 to 4 or 5 higher than what we anticipate. There are a couple of different types. A partial mole is when 2 sperm fertilize 1 ovum. Okay, we have way too many chromosomes. We have way too much for one little egg to be able to handle. It is not incompatible with life, alright? We can't have a whole extra set of chromosomes and expect everything to go hunky-dory. This is usually diagnosed after a spontaneous abortion around 8 to 9 weeks of gestation. The placenta is only partially fluid-filled. Some villi are vascular. So if we have some villi that are vascular, you're going to obviously see then some bleeding. These, in a partial mole, sometimes they contain embryonic or fetal parts as well as an amniotic sac. When you have a complete mole, you have 1 sperm fertilizes the egg. Okay, so that's good. But the egg is completely empty, which is completely random. But so we only have now one set of chromosomes, the paternal set. And when that happens, we have a very avascular placenta, and it's very only fluid filled. So again, you're going to see this earlier on in that earlier pregnancy, those first 12 weeks. You're going to have brown vaginal bleeding or spotting. As I mentioned, you're going to have perhaps a uterine size larger than normal. Along with that vaginal bleeding, you might also see some anemia. The uterine size being so large might also cause some abdominal cramping. We have severe morning sickness, and that correlates with the next symptom, high HCG levels. So as that HCG level is being pumped out by this rapidly dividing early placental cells, then what we end up with is this severe morning sickness because it's HCG that's making us vomit and have nausea. And it's going to be to the point that it's so severe that we're going to be able to pick it up on those fluid and electrolyte labs. When we do a vaginal ultrasound, we're not going to have any fetal heart rate. We're not going to be able to pick up anything there. And then this passing of the grape-like clusters, obviously that is going to refer to what we're actually seeing inside of the uterus. When we do a transvaginal ultrasound looking for that fetal heart rate, we're going to have this signature snowstorm pattern. It's a very specific pattern that is able to be picked up on the ultrasound and does not even have to be read by radiology. When we're talking about management, when we identify this versus ectopic versus like a complete or an incomplete spontaneous abortion, most of these are going to abort spontaneously. Some might require evacuation by way of that DNC. We might have to go in and do a little bit of help there. Hysterectomy might be an option if the patient so desires. When we're talking about long-term management of gestational trophoblastic disease, the provider is going to want to monitor serial HCG levels for potentially up to a year. There could be any residual trophoblastic tissue which could continue to spit out that HCG, which could convince the woman's body that she is still pregnant. So we're going to do weekly serum levels until that HCG level drops to 0, and then we'll repeat randomly, or at not randomly, but at intervals then throughout the year. Again, we're trying to make sure that every bit of that residual of that trophoblastic disease is gone. In the meantime, we're going to say, please do not get pregnant. So you might do a prophylactic methotrexate injection to prevent pregnancy during this time. We're not going to use an IUD. Okay, we're not going to go back up in there into that diseased area, but we can do an IM injection of methotrexate. These women are at very high risk for choriocarcinoma, so that's a malignancy of the chorion that metastasizes very rapidly. So again, this requires close monitoring. RhoGAM administration if Rh negative again, and then grief counseling as well. Cervical insufficiency or an incompetent cervix is when we have a weak cervical tissue. We could have painless, passive dilation of the cervix during the second trimester without any known cause. So that woman is going to have some vaginal bleeding. She comes in to get checked out, and the doctor says, you are actually dilated to 2 or 3 centimeters. And that's not great because we want to, it's way too early in the pregnancy to have this happen. So potential risk factors for developing a cervical insufficiency or an incompetent cervix, we could have like a history of a collagen disorder. Cervical trauma, so things like a past history of like a cervical laceration with a pregnancy, or something called a conization, which is treatment of abnormal cervical dysplasia. A forced previous dilation, so things like an elective abortion or a previous D&C where the provider has to use that instrument. Looks like a long, like funnel-shaped, cone-shaped instrument in which the provider, obviously with the woman being sedated, manually opens that cervix. Well, if that cervix has been forced open in the past, when it's not designed to be opened or not ready to be opened per se, then that cervix could potentially be weaker. Anatomical abnormality. When we're talking about here, we're looking at a shortened cervical length, like the woman's cervix just isn't long enough like it should be, which then you have this growing fetus and the uterus is starting to grow, and we don't have the space that we should have. And then obviously during the laboring process, then we do want that cervix to thin and shorten, but not at 20 weeks of gestation. So usually we're going to note a cervical insufficiency when we're talking about patient history. We're going to red flag if we consistently have pregnancy losses along that 4th to 5th week of gestation. So we're also going to look for a history also of cervical trauma. If the provider is able to note that we've had that cervical laceration, if we've had those D&Cs in this past, or when we're doing a speculum exam and the provider notes a funneling or beaking, which is essentially the cervix dilating and then the bag of water is kind of poking through, okay, through that open cervix. We can do a vaginal ultrasound earlier on in the pregnancy, and when we're doing that, we're able to determine kind of that cervical length, and that might also cue us into a problem. And when we do the vaginal exam, if she notes any vaginal bleeding, we take a peek and see what's going on, and we have dilation. Okay, now we are able to diagnose perhaps a cervical insufficiency. Backache, vaginal discharge. Basically, she's going into labor, at this point. So what are we going to do? We're going to encourage this woman to be on bed rest, and pelvic rest. So a pelvic rest is nothing in the pelvis. No penises, no tampons. You shouldn't be putting a tampon up there anyway when you're pregnant. No douching, okay? No toys, no sex toys. Nothing in the vagina, all right? So then the next thing is a cervical cerclage, which is here. So a cervical cerclage is what we call a purse string suture that's placed around the cervix. 80 to 90% of people who have been identified to have a insufficient cervix who have a cervical cerclage go on to have a viable pregnancy. So this works once we identify it. There are some risks to having a cervical cerclage, including perhaps the provider hits something, we have an inadvertent rupture of membranes. Perhaps we irritate the uterus and we end up in preterm labor. Perhaps we introduce infection to that area and we end up with chorioamnionitis. However, if we note this early enough along in the pregnancy, if we recognize that this woman has an insufficient cervix, then at 12 to 14 weeks, this is placed as a preventative prophylactic measure, and we remove it at 37 weeks, and that woman is allowed to progress and have that baby vaginally. Again, during this time, we'll be told to be on bed rest, be told to be on pelvic rest, and then they are to notify their provider immediately if they have any symptoms of cramping or low back pain. So after 20 weeks of gestation, when you're talking 20 weeks of gestation to 23 weeks of gestation, that can be a really iffy time period as as to whether this baby is going to be viable or not. Usually during that time period, the woman is allowed to progress in her labor and then allowed time to be with her baby after the baby is delivered, and as that baby passes away. After about 24 weeks of gestation, if we have vaginal bleeding, we're able to bring that patient in and hopefully be able to still leave the hospital at some point with a healthy mom, healthy baby. One of the things that we're going to be very concerned about is something called a placenta previa. And I know that I have talked about it several times, but essentially what we have here is a placenta that decides to implant in the lower segment of the uterus. It can be a complete placenta previa, in which the placenta completely covers the cervical os, or a marginal, so maybe only partially covering the cervical os, or a low-lying placenta that is still concerning. If it's a low-lying placenta that we identify at 20 weeks of gestation, then at that 20-week anatomical ultrasound, then typically what you'll see is repeat ultrasounds looking for that low-lying placenta to gradually move up the side of the uterus as the uterus expands for the fetal growth. So what are risk factors for having a placenta previa? C-section, okay? Those placentas, they really love to attach themselves right along scar tissue. And when we're talking about where we have C-sections, it's in that lower uterine segment, usually, that low transverse incision. If we have a placenta in a later pregnancy that decides to implant itself there, that's going to place us at risk for developing a placenta previa. Advanced maternal age, because being a little bit older than in your pregnancies just put you at risk for everything. Multiparity, so multi-fetal gestation. Smoking. So how does smoking, affect things? Well, we have a uteroplacental insufficiency, the placenta has to be essentially larger. It recognizes that there's not getting enough oxygen to the fetus, so the placenta abnormally grows larger. And in doing so, you have a larger uterus, a larger placenta, and now we're more at risk for it covering more parts of the uterus. Again, another risk factor for this would be a suction DNC. Again, we're looking at scar tissue. So, placenta previa, painless, bright red vaginal bleeding after 20 weeks of gestation. Observation is the first thing that we're going to do. If they are less than 36 weeks, we're going to carefully monitor fetal well-being. If it's a complete placenta previa, we're going to do a C-section, because there's no way that this woman can develop or deliver vaginally and that baby be able to withstand the stress of delivery. If it is marginal, if it's just covering a portion of that cervical os, these women, as long as they're hemodynamically stable, we can attempt a vaginal delivery, but they are at definite risk for a postpartum hemorrhage, as that part of the uterus cannot contract then very well. And then a placental abruption. Now, placental abruption, a placental abruption is in which the placenta spontaneously separates from the normal part of the uterus. So again, we can have a marginal placental abruption, in which we have less than 500 milliliters of blood that are released, or just a tiny flap of the placenta that has come apart. We noted on ultrasound, and we were watching it super close. A marginal, severe, or concealed. So a concealed placental abruption is really, really bad, because essentially the outside of the placenta still adheres to the uterine wall, but the remaining portion of it like an upside down bowl on a surface is just filling with blood. When that happens, you don't have the vaginal bleeding because you just have this space filling with the blood. Whereas with an apparent placental abruption, you have bright red vaginal bleeding. If you have a concealed placental abruption, you may or may not have abdominal tenderness. You're going to have uterine tenseness and rigidity, as we've got that hemorrhage within that organ. We have decreased fetal movement. In this case, our first goal is to restore blood loss. Okay. If it's mild, we might be able to do IV fluids to kind of help out with that hypovolemic situation. We're going to do continuous fetal monitoring. We may need to just go to the C-section. Again, healthy mom, healthy baby. That's what we're going for. The risk factors are going to be the same as for a placenta previa. We're going to add in there hypertension, cocaine use, and alcohol use. Uterine rupture. So uterine rupture is another emergency, kind of related here. So we have a uterine rupture is just that. The uterus opens. Usually it's going to go along the C-section, old scarring, because that scar tissue of the uterus is weak and it's unable to withstand the force of the pregnancy or the labor, the tension of labor. So if this could be like, if the mother would like to try to have a vaginal delivery after she's had a C-section, she has to be counseled on the risks for a uterine rupture. So a VBAC is that vaginal birth after a cesarean, or a TOLAC, a trial of labor after a cesarean, is going to be a high-risk situation for a uterine rupture. Symptoms include tearing abdominal pain. So if a rupture occurs, we're going to have the fetus rise upward into the abdominal cavity because it's basically free-floating. There's a high likelihood of fetal demise. The treatment is going to be C-section, immediate abdominal surgery, likely to have a hysterectomy, and just a bad situation all in all.